Okay, start.
Okay. This is the base of the heart, which is showing normal pulmonary veins on left side and right side, which are draining into left atrium. If you go for anomalies, it could be in the form of anomalous venous connections or anomalous drainage with normal connections, stenotic connections, and abnormal number of pulmonary veins. These are like four or major forms of different categories. If you go for embryology proper with the development of venous system of embryo, there are three main veins, which is vitelline vein, umbilical vein, cardinal veins. Where the vitelline veins, these they veins carry blood from yolk sac to the sinus venosus. These are also called ophalomesenteric veins. Umbilical veins, which carry oxygenated blood from the chorionic villi to the embryo, and cardinal veins, which are proper veins which drain the body of the embryo. And venous system of the embryo, if you see the cardinal system forms on the above the heart, that is right cardinal venous system develops into the right SVC, whereas the left cardinal venous system mostly disappears and may potentially develop into left SVC, that is occurs in less than 1% of the individuals. The umbilico-vitelline veins develop into the IVC, portal vein, and venous system and ductus venosus. This is around 27 to 29 days in the lung buds where the splanchnic venous plexus is present, which has been connection with the cardinal veins there, which is here. It is these lung buds are enmeshed by the vascular plexus of the foregut, that is splanchnic plexus, and a small evagination arises in the posterior wall of the left atrium to the left of the developing septum secundum, which forms the common pulmonary vein. Later, around 32 to 33 days, that is by the end of first month of gestation, this common pulmonary vein establishes connections between the pulmonary venous plexus and the sinoatrial portion of the heart. And connections between the pulmonary venous plexus and the splanchnic plexus are still present. This is splanchnic plexus, where it was denoted as S. These are the pulmonary venous plexus. This is common pulmonary vein, which has been evaginated from the posterior surface of the left atrium to the left to the septum secundum, developing septum secundum. Over the time, the connection between the pulmonary venous plexus and the splanchnic venous plexus involutes. And after that, around the term, this common pulmonary vein invaginates into the posterior surface of left atrium, so that individual pulmonary veins opens into the left atrium. Any hindrance at these stages of development will lead to pathological consequence, which we further discuss. This is the nutshell of the embryological development of venous system, where the connections with establishment of common pulmonary vein, there is atresia of the connections between the splanchnic and pulmonary venous plexus, and invagination of common pulmonary vein. If you see, this is our today's topic of interest is TAPVC. In addition, what is the pathology of TAPVC is, there is early atresia of the common pulmonary vein, while pulmonary systemic venous connections are still present. What it means is, there is a loss of connection between the common pulmonary vein along with LA, where still these connections are present. This cardinal vein and pulmonary venous connections are present, which will lead to form a venous confluence along with, which is a component of pulmonary venous plexus, which lead to attach to the left innominate vein through the vertical vein, which are the systemic venous connections. This is a pathophysiology where there is early atresia of the common pulmonary vein, while pulmonary venous systemic connections are still present. If it occurs for the all four veins, it is TAPVC. If it is occur for the few of the veins, it is PAPVC. Where if you see, if it is there is late atresia of the common pulmonary vein, where these are already atresia occurs in between the systemic and venous system, it will form into two things. It could be atresia of the common pulmonary vein, or it may form into cord triatrium. That is when CPV, common pulmonary vein, is stenotic and it dilates, it will lead to cord triatrium. This is another form of anomalous venous drainage, where there is absorption of common pulmonary vein occurs within time, and pulmonary venous drainage is abnormal with normal connection of pulmonary vein. As we have seen previously in this, if you observe sinus venosus defect, the true defect is the deficiency of common wall between the right SVC and the right upper pulmonary vein. If you see, this is the LA, and there is a defect between the, usually this is the SVC, which is in relation to the right pulmonary vein. The right upper pulmonary vein is normally draining into LA, and the common pulmonary vein involution occur at the predicted time. But there is a deficiency in between the common wall between the right upper pulmonary vein and SVC, which is occurs if it is like sinus venous of SVC type. There is a common wall deficiency in between the SVC and right upper pulmonary vein. If it is a unroofing of right upper and lower pulmonary veins into the right atrium, it is sinus venosus defect of right atrial type. Another type in this abnormal pulmonary venous drainage is malposition of septum primum. When septum secundum is absent, the growing septum primum displaced towards the LA, where the RUPV is normally destined to LA, but due to division of septum, it is functionally opening into the RA, where there is connection of RUPV to the RA because of anomalous drainage, not because of anomalous placement of RUPV. It can be occurred in half or all the pulmonary veins into morphological RA. This is the discussion which is showing pulmonary venous confluence with the membranous obstruction with a small opening with the low pressure LA chamber and LA appendage. This is cor triatrium. What is the pathophysiology in cor triatrium? There is if you see cor triatrium pathophysiology, late atresia of the common pulmonary vein after the pulmonary and systemic connections are obliterated. This is the only defects I have explained. That is normal absorption of the common pulmonary vein associated with the defect that result in abnormal. That is sinus venosus defect or malposition. And TAPVC and PAPVC, as we have seen, there is atresia of the common pulmonary vein where pulmonary and systemic venous connections are still present. Another thing is, if atresia of the common pulmonary vein occurs later where pulmonary venous connections are obliterated, it will lead to atresia of common pulmonary vein, or if stenosis is this is cor triatrium, and abnormal absorption of common pulmonary vein into LA, which may lead to stenosis of individual pulmonary vein or abnormal number of pulmonary veins. These are the types of abnormal venous drainage of the heart in overview. If you go to the proper topic, that is TAPVC, this is total anomalous pulmonary venous connection. It is a cardiac malformation in which there is no direction between the pulmonary vein and the left atrium. Rather, all the pulmonary veins connect to the right atrium or one of its tributaries, either SVC, coronary sinus, or IVC, or portal vein. If you see, it was first described by the Wilson in 1798 in monostrous formation of the heart, in which superior caval veins was joined by the trunk, formed by two large veins coming out of the lungs. And first successful open repair was done by Muller. Incidence is 4 to 6 per 1 lakh live births. Accounts for 2% deaths due to CHD in first year of life. In one study, it is of 1.5% of all CHD. In India study, it's around 2.08 and 0.74. Male preponderance in infradiaphragmatic TPC, this is around 3.621, equal in other varieties. However, New England Regional Infant Cardiac Program, 2/3 of the supracardiac and cardiac connections were males, whereas infradiaphragmatic variety, no preponderance was there, which was opposite to previous one. Genetics and epidemiology, this is mechanism of transmission is unclear. Monogenic pattern of inheritance is suggested. In Baltimore and Washington infant study, possible association with exposure to lead and paints and pesticides was described. Associated syndromes are Holt-Oram, Klippel-Feil, Sacher-Mann syndrome, asplenia with polysplenia, cat's eye, and phacomelia. Classification, there are various classifications depending upon the level of connection of this abnormal pulmonary venous confluence to the systemic venous. That is at the supracardiac level. If you take the heart, it is at the supracardiac level, or at the cardiac level to the coronary sinus, infracardiac level to the portal vein or the IVC directly, or anomalous connection at 2 or more of the above levels. Either 3 or mixture could be there. This is another classification which are like more or like same, but which is not commonly used. That is connection to the right atrium and right common cardinal system. That is SVC or same, or connection to the left common cardinal vein. That is left innominate vein or left SVC or the coronary sinus, or connection to the umbilical vitally system. That is portal vein. This what we have discussed in the at the embryology, where cardinal system of right, connection to the cardinal system of right, connection to the left cardinal system, or connection to the umbilical vein system. And another classification is supradiaphragmatic without pulmonary venous obstruction and infradiaphragmatic with the pulmonary venous obstruction. These are the
One more
various
is
levels
there.
and how. Sorry.
Darling class.
Hello.
One more classification is there, na?
What is it? This Craig et al. Craig et al. Is there. Both are same. Here Craig et al. And both are same.
Darling classification also same, huh?
Oh, same.
Darling is
And if you
Craig.
see, anomalous connections, if you see, connections to the right SVC or right azygous vein, and the connection to the left SVC are most common side. Most common is this one. Here I want to say one thing. So what is the difference between if there is a pulmonary venous confluence, which is connecting to the left innominate vein? This is through the vertical vein. I want to tell that what is the difference between vertical vein and the left SVC. If this pulmonary venous confluence, if it is connected to the CS, this is SVC, left SVC. If it is connected to the left innominate vein, which is draining into the right SVC, that is the connection between the PVC and LIV is vertical vein. If it is draining into the coronary sinus, this is left SVC. This is the difference between vertical vein and left SVC. And connection to the coronary sinus, entire anomalous pathway is within the pericardium. Connection to the umbilical vein system, that is portal vein is the most common, along with ductus venosus or to one of the hepatic veins or the IVC, most often associated with pulmonary venous obstruction. These are the various series where it has been different connections has been showed. That is Burrows and Edwards, Lucas et al. And Delisle et al. Where the most common is left innominate vein in different series also, followed by coronary sinus in some, and right atrium, right SVC, and portal system and multiple sites. And whenever there is TAPVC is present, the longevity or prognosis depends upon the timing of treatment is depending upon the whether there is obstruction is present is not, and there is proper mixing of blood is there or not. It can be done if there is interatrial connection or there is a connection between the right and left system is there. If you see if there is obstruction at the interatrial septum, longevity in the TAPVC depends upon the size of the ASD. Restrictive ASDs are associated with increased mortality. And if you see obstruction either at the ASD or at the anomalous venous channel, there could be intrinsic narrowing of the walls of anomalous channel or extrinsic components could be there. If you see vertical vein in TAPVC to the left innominate vein passing between the MPA and the bronchus, there could be extrinsic compression by the both of them. In infradiaphragmatic PVC, constriction occurs as it traverses the esophageal hiatus, and ductus venosus can undergo constriction. When the anomalous connection is to the portal vein or one of its tributaries, hepatic sinusoids are interposed between the pulmonary venous and the heart. Infracardiac type is usually obstructive, while supracardiac are often non-obstructive. This is one of the classifications which I have discussed. Associated cardiac anomalies are usually associated with PF or OSASD, which are better for admixture, and PDA in 20%, VSD with TZ or DORV, single ventricle, single atrium, coactive aorta, and pulmonary valvular stenosis. PVD to the right atrium is associated with the visceral heterotoxin polycythemia, usually. If you come to the physiology, TAPVC physiology and the survival of child depends upon the presence of right to left intracardiac shunt, either in the form of PFO or ASD and PDA. while the prognosis depends upon the size of the interatrial communication and presence of obstruction, whether or not the pulmonary veins enter below the diaphragm. Because if they are going infradiaphragmatic, there is more chances to get obstruction at multiple levels, either it is the hepatic sinusoids while entering into the diaphragm to the esophageal hiatus. If in pathophysiology, during the fetal life, pulmonary blood flow is small, and the combined systemic and pulmonary venous rectum to the RA is only minimally increased. Hence, the stimulus for the development of large intra-atrial communication is minimal, as there is no large inflow to the right atrium, but some degree of restriction to the flow occurs as patent phenomenon is common. But in patients with the restrictive intra-atrial communication, the amount of blood reaching the LA is limited and systemic output is reduced. Once the birth is occurs over the days, the pulmonary vascular resistance gradually decreases after birth, and demands for systemic blood flow increases with rapid growth of the infant. There will be massive pulmonary overcirculation ensues, which is equal to 5 to 6 times the systemic blood flow, where entire blood is returning into the RA, and therefore increased right atrial pressure results in pressure elevation in the congestion of both venous circuits. Here, at birth, the distribution blood between it is approximately equal, but in first few weeks of life, as the pulmonary vascular bed produces decrease in the PVR, there is progressively large proportion of the mixed venous blood traverse the pulmonary circuit. That is around 3 to 5 times, which is usually normal. Because there is adequate mixing in the RA, the saturation over the RA, RV, pulmonary artery, and LA, LV, and aorta is usually more than 90%. Whereas the further arteries, it may vary depending upon the anomalous drainage. Because if it is entering into the IVC, that may vary. In this non-obstructive, adequate mixing in the RA is the rule. Thus, as I told, that saturation is normal, that is more than 90%, and that is same that of RA. Other systemic arteries may vary considerably depending upon the type of the TAPVC. With the venous obstructions, what happened with venous obstruction? There is elevated pressure in the pulmonary venous channels, which is transmitted back to the pulmonary capillary blood, which lead to pulmonary edema results when the hydrostatic pressure in the capillaries exceeds the osmotic pressure of the blood. Mechanism that tend to prevent this pulmonary edema is increased pulmonary lymphatic blood flow and alternative pulmonary venous bypass channels and altered permeability of pulmonary capillary wall and reflex pulmonary arterial congestions. This last mechanism results in decreased pulmonary flow, pulmonary hypertension, and right ventricular hypertension and hypertrophy, ultimately right heart failure. Clinical features. If you see, the clinical features varies whether it is obstruction is present or not. Without obstruction, they usually asymptomatic at birth, tachypnea and feeding difficulty usually in the first few weeks, followed by frequent respiratory tract infection in view of increased pulmonary blood flow. Cyanosis is mild because of adequate mixing of blood in RA. Gradually, they develop right heart failure, as we discussed, and pulmonary arterial hypertension. Cardiac failure in most patients occurs prior to 6 months of age, which they present with hepatomegaly is always present, and peripheral edema is present in about half of the cases. If you go with pulmonary venous obstruction, they are present more aggressively. They present with tachypnea and tachycardia and cyanosis within few days of life, usually not within first 12 hours of birth, because differentiation from patients with respiratory distress syndrome. And dyspnea is severe because marked pulmonary venous congestion, as we are told, if there is obstruction, there will be backflow and increased hydrostatic pressure. If it is left untreated, death may occur from pulmonary edema and RV failure within few days or weeks of life. Infradiaphragmatic TAPVC, cyanosis and dyspnea are attenuated while straining and swallowing because it is related to abdominal pressure. Interference of pulmonary venous outflow by increased intra-abdominal pressure and impingement of esophagus on the common pulmonary vein as it exits through the esophageal hiatus. And Northern Great Plains Registry of Congenital Heart Disease, which showed 74 patients of TAPVC without pulmonary vein obstruction. There will be 56% of symptoms in first month, remainder in the first year. Whereas with the obstruction, there is 72% of symptoms in the first month, remainder in the early in the first year. Those who survive their first year almost always have supradiaphragmatic connections and low pulmonary vascular resistance and non-restrictive atrial septal defect. This sentence will indicate that favorable physiology, that is having supradiaphragmatic connections, which are normally non-obstructive, and low pulmonary vascular resistance and non-restrictive ASD because of adequate mixing and going right to left flow, blood flow. Examination. These examination findings I will discuss, which are different from both with obstruction and without obstruction. Usually physical appearance, mild cyanosis with features of congestive cardiac failure present. Arterial pulse, small volume is there because of decreased LV stroke volume. JVP, if it is non-restrictive interatrial communication, it resembles that of isolated OSASD as like waveforms in LA only. If it is restrictive with pulmonary hypertension, there are large A waves are present. Inspection and palpation, left LV impulses are impalpable because of left-sided flow is decreased, and left parasternal heave with the hyperdynamic RV impulse due to increased flow. It is not a feature of TAPVC with obstruction because of there is back flow and the forward flow is decreased from RV side also. In auscultation, if you see in TAPVC with obstruction, S1 is loud with a wide flexed splitting of S2 and RVS3 with S4 and increased atrial contraction. These are due to increased blood flow to on RV side. Pulmonary ejection systolic murmur, tricuspid flow mid diastolic murmur. If the pulmonary hypertension sets in, there is pulmonary ejection sound, attenuation of these murmurs, both, and inspiratory splitting of second arch sound and Gram-Still murmur could be there, PR murmur. If you see with TAPVC with obstruction, the clinical condition is grave with minimal clinical findings. Early presentation of PH is present. Apical impulse is RV type because of PH. S1 is normal and closed split of P2 with loud P2. Frequently murmurless. Occasionally loud continuous murmurs over the site of venous narrowing may present. High frequency holodiastolic murmur with the suggestion of TR with the background of pulmonary hypertension and RV failure. Coming to the investigations, these are like common with the incomplete right bundle branch block with the prolonged PR interval. In the setting of pulmonary hypertension, there could be P pulmonale along with right axis deviation, tall precordial R waves, the deep left precordial S waves present. Chest X-ray, there are two different X-rays, that is for without obstruction and with obstruction. This is the figure of 8 or snowman appearance, which composed of anomalous vertical vein on the left with the left innominous vein superiorly, which dilated SVC on the right. It is not usually present in the first few months of life. This is a later finding. These are the labelings which are showing these things. This is the typical appearance of snowman. If you see without with obstructive TAPVC, because of pulmonary edema, there will be diffuse reticular pattern is there, and cardiac size can be normal without right side enlargement, and Kerley B lines may present. This pattern also seen in other causes of pulmonary venous obstruction also. Echocardiography, whenever 2D echo with color Doppler is definitive non-invasive method for diagnostic of TAPVC, a sensitivity of 100% and specificity of 85% is claimed for detection of obstruction by 2D echo with color Doppler. Whenever you are doing 2D echo, these points should be kept in mind while evaluating the disease. The first one is size of the pulmonary veins and connection of all 4 major pulmonary veins to the confluence and any additional pulmonary veins, and size of the pulmonary venous confluence and its relation to the left atrium, and course of the pulmonary venous channel whether there is any obstruction after the origin from the common pulmonary venous confluence, and to evaluate the intra-atrial communications for obstruction and additional cardiac anomaly. In this, each point is having prognostic significance. This features most common to all TAPVC are signs of RV volume overload and inability to image pulmonary veins entering into the LA. These things are common for TAPVC. And size of the individual pulmonary vein at the time of diagnosis is a strong independent factor of survival. Smaller pulmonary veins are associated with poorer prognosis and higher surgical mortality, even after repair of TAPVC. This is one study which is showing the pulmonary vein sum in millimeter per meter square and number of patients alive or dead, which are after repair of TAPVC, where the most of the patients are having increased mortality, which is with a decreased pulmonary vein diameter, where those are with a good diameter having good post-operative prognosis. This is the few echo pictures. This is a crab view, which is showing aorta PA with all four pulmonary veins, which are draining into common pulmonary vein, which further draining into SVC. Here, this is another thing where it is connected to coronary sinus, where pulmonary venous confluence, which is draining into coronary sinus, along with vertical vein, but it's usually called LSVC. And this is another is where IVC type, where which is coming from the vertical vein from the pulmonary venous confluence through the diaphragm, which is connecting to IVC. These are the another parameters which are where suprasternal long axis, which is showing a vertical vein, which is draining into left innominate vein into right SVC. This is phasic pulmonary venous flow in a vertical vein, where innominate vein is that is, if it is phasic means there is absence of pulmonary venous obstruction. If it is continuous and there is no with the respiration, it means there is indicating the pulmonary venous obstruction. This is a subcostal view, which is showing the pulmonary venous confluence draining into the descending vein, which is draining into the portal vein. Slide is not on. And after the 2D echo, we have further investigation like CT and MRI. CT excellently depicts the vascular structures peripheral to the heart, and disadvantage of CT that is requires is ionizing radiation and IV iodinated contrast material. And MRI is the preferred imaging technique for evaluation of pulmonary venous structures after echocardiography. Lack of ionizing radiation and need for single IV bolus gadolinium contrast are advantages of MRI. Cardiac catheterization is reserved for precise examination of pulmonary veins and their obstruction. The pathognomic finding is oxygen saturation in all chambers and great vessels are nearly identical. When TAPVC is to left innominate vein or right SVC, SVC blood here, if it is if TAPVC is going to left innominate vein and right SVC, that SVC blood preferentially goes into the tricuspid valve, across the tricuspid valve, and IVC blood preferentially goes into the left atrium if there is ASD, resulting in there is an increase in the saturation. PA saturation is greater than the systemic artery saturation when it is like this. In cardiac catheterization, if you see this is the common confluence along with four pulmonary veins, which are formed the vertical vein where there is a connection, obstruction of the connection to the innominate vein, which is connected to the SVC. This is obstructive type, and RVA PA pressures are increased and may be equal or more than the systemic pressure. Selective pulmonary arteriography, when to be done is if pulmonary veins cannot be entered directly, then selective right pulmonary artery angiography to be done, which should be seen in Leo phase. This is another one where the confluence has been connected to vertical vein. This is infracardiac type. Via descending vertical vein to the portal vein and it is termed as the tree in winter. This term is known as tree in winter. In neonates, umbilical vein catheterization allows direct injection of the contrast in anomalous connections in the infradiaphragmatic type of TAPVC. Natural history is 10 to 20% survive first year of life, 50% survive beyond 3 months. Those who survive first year without surgical treatment have stable course till 10 to 20 years. In the second decade, pulmonary vascular disease occurs where there will be increasing cyanosis occurs. And the prognosis is better for non-obstructed pulmonary venous dryness compared to obstructed pulmonary venous dryness. So whenever the patient with TAPVC comes, what should be done in emergency basis is immediate endotracheal intubation with hyperventilation with 100% O2 to maintain a PaCO2 of 30 millimeters of mercury and correction of pH, and metabolic acidosis treated with bicarbonate infusion, cardiac failure treated with inotropes and diuretics. Isopretinol has specific merit because of pulmonary vasodilatory properties, which will increase the flow, and PGE1 infusion to be given to maintain patency of ductus venosus to decompress the pulmonary veins in obstructed TAPVC in infradiaphragmatic type. ECMO in infants with refractory heart failure, and balloon or blade atrial septostomy, which is a palliative procedure which no longer recommended, which delays definitive procedure, and no in pulmonary venous obstruction. Surgery, the goal of the surgery is to create unobstructed egress of the blood from pulmonary veins into the left atrium. Various approaches for the surgery, that is posterior approach and right atrial approach and superior approach. Just I'll show the pictures of various this one. Indications are once the diagnosis is made, operation should be undertaken immediately in any neonate or infant. Surgical intervention during the first few days or weeks of life, usually within 6 months of life. Diagnosis between 6 to 12 months, immediate surgery to be done. Diagnosis in childhood or early adult life is done, depends upon the PVR measured at preoperative cardiac catheterization after 100% O2 and inhaled nitric oxide. If PVR is less than 8 wood meter square, you can go for the surgery. If PVR is more than 8 wood per meter square, chronic pulmonary vasodilatory therapy may be considered to increase operability. It should be reassessed later. This is a posterior approach, which is showing various pulmonary veins and confluence has been resutured. This is right atrial approach, which I am not going into details. And this is repair of total anomalous pulmonary venous connections to the coronary sinus, which is one Prague method. The surgical outcomes, surgical mortality has decreased from 50% in 1970s to the 2 to 20% in recent studies. Modes of death after repair are cardiac failure, hypertensive pulmonary artery crisis. Complications in the early time are pulmonary edema, pulmonary hypertensive crisis, phrenic nerve damage, and rhythm disorders. Later, pulmonary venous obstruction, anastomotic strictures, and pulmonary venous stenosis. And pulmonary edema, these are due to non-compliant left heart and increased left atrial pressure due to unexpected increase in this one. And diuretics are useful for the treatment. In pulmonary hypertensive crisis, hyperventilation with 100% oxygen and inhaled NO is the treatment of choice. Infusion of prostacyclin may be useful. In rhythm disorder, junctional rhythms and various types of heart blocks are common in cardiac type of TAPVC repair. And pulmonary venous obstruction could be there, two causes, either due to severe anastomotic stricture or pulmonary vein stenosis. Risk factor are original diaphragmatic, previous infracardiac or mixed TAPVC or obstructed TAPVC. Anastomotic stenosis occurs in 10% of patients within few months of repair. No relationship between the suturing techniques and the stricture formation. Pulmonary vein stenosis is less common, appears later due to diffuse thickening and fibrosis of venous wall, usually lethal despite reoperation. Thank you.